Hello, this is Dr. Pasion-Gonzales, and this is part 2 of Chapter 14, Psychological Disorders. Hey, so this is part 2 of Chapter 14, and primarily we're going to spend our time talking about schizophrenia and personality disorders. We're also going to touch a bit on dissociative disorders, okay? Let's start with schizophrenia. Now, schizophrenia is more than just hearing voices, just like major depressive disorder from last week is more than just feeling sad, okay? Although hallucinations are one of the hallmarks of schizophrenia, there are disturbances in other areas as well. From the chapter, be sure you know the difference between hallucinations and delusions. So they're both considered psychotic symptoms, but the biggest difference is hallucinations are sensory experiences that are disrupted. So a person hears voices that other people don't hear or sees things that other people don't see. Auditory and visual hallucinations. With delusions, they're more of distortions in beliefs, where a person might believe someone is out to get them when they're really not, or that's paranoia, by the way. Or a person might have delusions of grandeur, where they think that they have special powers, or they think there's somebody famous or important, like Jesus, for example. So they don't experience the world differently as with hallucinations, they just interpret the world differently. Now remember that psychotic symptoms can be present with bipolar disorders, severe depression, and certain types of drug use. So hearing voices or being paranoid does not by itself define schizophrenia. Also keep in mind that with schizophrenia, the hallucinations tend to be auditory. They tend to hear voices. You tend to see visual hallucinations more with drugs or organic brain problems. Okay, so people with true schizophrenia don't typically say that they're seeing things that other people don't see. It's more that they hear things that other people don't hear. So, along with the psychotic symptoms, you see very clear disruptions in the person's speech and their ability to organize their thoughts clearly. The book refers to the term word salad, and in this situation, a person uses words or phrases, but they cannot really connect them in a way that makes any sort of sense. So they just come out like a jumble. And there's also the stereotype of the person mumbling to themselves, where their speech seems to jump randomly from thought to thought. That can also be very common with schizophrenia. So it's the hallucinations, sometimes delusions, but real disruptions in their speech pattern because their thoughts are very difficult for them to organize clearly. Okay. And lastly, schizophrenia has a significant impact on the person's mood or emotions. We call this affect. The term flat affect actually refers to a presentation where the person presents little or no emotion. Now, for some people, you see just the opposite, where their emotions can be extreme and often don't seem to fit the situation or the context that they're in. This and to make matters worse, they can also be responding to some internal stimuli. So they may be laughing at something or getting angry at something that is not actually going on around them. Now, the book refers to positive and negative symptoms, and this can be a little bit confusing. So the thing to realize is positive and negative symptoms don't refer to positive and negative in terms of good or bad. It's more of a mathematical term. So with positive symptoms, you see changes in behavior that aren't typically present for most people, like hearing voices or delusions, things like that. With negative symptoms, you see symptoms that are typically there for most people, but are absent in this situation. So, flattened affect would be a good example of a negative symptom. Most people can express that. In these situations, it's not there. The video in section 14.5, I think, does a pretty good job of describing both positive and negative symptoms for schizophrenia. Now, There seems to be a very strong biological connection between genetics and schizophrenia. Although you'll sometimes hear about some pretty dramatic events which seem to trigger schizophrenia, for the most part, it's believed that it's a biological or genetic disorder. Schizophrenia usually presents itself in late teens, early 20s. And we know from the research that for folks who have a genetic predisposition towards schizophrenia, for example, close family members with schizophrenia or other pretty serious mood disorders, um, adding alcohol or other drugs can bring on those schizophrenia symptoms, can actually bring on the disorder earlier in life. We know that alcohol and drugs makes the symptoms of schizophrenia worse and usually results in poor treatment. So the takeaway here is alcohol and drugs are not a good mix for schizophrenia or for folks who have a family history of schizophrenia. It's bad news. Although life stressors can sometimes bring on schizophrenia earlier, I think it's fair to say that you don't create schizophrenia. Without that genetic predisposition, it's not usually going to present itself on its own. So, if someone is showing psychotic symptoms, such as hearing voices, or they're presenting as pretty paranoid, delusional, how do you differentiate schizophrenia from bipolar disorder or from major depressive disorder with psychotic symptoms? Well, one of the big things you look for is the stability of the symptoms. With schizophrenia, those symptoms are pretty much there all the time. Okay, with a bipolar disorder, those symptoms are only present during the manic episode itself. And with major depression, the psychotic symptoms only occur when the person is really, really, really depressed. So at the peak or height of a severe depression. Also, you would look for other symptoms such as disruptions in thinking, the content and quality of their speech, as well as the inappropriate affect or mood, which we talked about earlier. I just want to mention a few things about dissociative disorders. They're very, very tricky because they're very rare and they're not well understood, even amongst mental health professionals. Probably the most well known dissociative disorder is a dissociative identity disorder. Sometimes you'll hear the initials DID for that. Used to be called multiple personalities, right? Where basically you'll see two or even more personalities emerge at different times from the person. In the 25 years that I've been a psychologist, I think I've probably seen two people who I thought legitimately had a dissociative identity disorder. So it's pretty rare. It's pretty uncommon. It is commonly believed that dissociative disorders are the result of some pretty dramatic trauma that a person has experienced, and the idea would be that the dissociation occurs as trying to find an extreme measure to deal with extreme traumas, usually over a long period of time. Okay, let's talk about personality disorders. Now, personality disorders are intriguing for a couple of reasons. They typically develop early in life and seem to be a pervasive way of dealing with the world and other people. They're very stable traits, which is why they're called personality disorders, because they seem to just be ingrained into how the person is. And they can be quite difficult to treat in some respects because there's not just a single specific area that you're dealing with, for example, a phobia or, depression. So it makes it harder to find a good focus for treatment. Personality disorders are primarily problems with self identity and interpersonal functioning. To meet criteria for a personality disorder, there must be a persistent, inflexible, a pervasive maladaptive pattern, and inexperience that, quote, deviates markedly from the expectations of the individual's culture, and leads to distress or impairment. Now, this is from the DSM-5, which I think we've talked about. That's our manual that we use to diagnose people. Now, the book highlights a few of the personality disorders. I think they went over paranoid personality, antisocial, and borderline personality disorder. So let's just mention a few things about those. Someone diagnosed with a personality disorder, they can present as delusional in the sense that the paranoia is pretty strong, a persistent sense that someone or everyone is out to get them. I think of the stereotype in The Simpsons, of all places, of the gun shop owner, Herman, I think is his name, with the conspiracy theories. That sort of fits. Again, the question comes up: when do you know if you see some paranoia in the person? When do you know if that's a personality disorder? A psychotic disorder is what you'd see with schizophrenia, or maybe just part of the mania from someone with a bipolar disorder, or it could be even related to severe depression. This is why we go back to the DSM for a reference, and why it is irresponsible to try and diagnose your family, your friends, and certainly yourself without some real training in this area. Okay, let's talk about borderline personality disorder. It seems to me that people very often mix up bipolar disorder with borderline personality disorder. Since the borderline personality disorder can show quick and powerful mood swings that look manic, right? You tend to see those extreme and rapid mood shifts more with a borderline personality than the bipolar disorder. With a borderline personality disorder, you see a lot of instability and extremes in terms of how well they regulate emotions, which frankly is not very well. You see extremes and instabilities in their relationships. For example, you might be the person's best friend or their worst enemy, but probably nowhere in the middle, right? The whole stereotype about I love you, I hate you, don't leave me. You tend to see strong signs of impulsivity and some real disruptions in self-image. It's hard for them to have a sense, a good, strong, stable, reliable sense of who they are, which, as you can imagine, would be very distressing for a person. So, from the DSM-5, here there's 9 criteria. The person has to endorse 5 of these 9 criteria. First of all, frantic efforts to avoid real or imagined abandonment. 2, a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization, I love you, or devaluation, I hate you. 3, identity disturbances, marked and persistently unstable self-image or sense of self. Number 4, impulsivity in at least 2 areas that are potentially self-damaging. So this could be spending money, substance abuse, reckless driving, binge eating, something like that. 5, recurrent suicidal behavior, suicidal gestures, threats, or self-mutilating behavior. 6, affective instability, meaning mood instability. Okay, intense episodes of dysphoria, feeling really, really sad, irritability or anxiety, which usually lasts just a few hours, rarely more than a few days. Okay, so again, that part's going to look real different from a true manic episode. 7, chronic feelings of emptiness. 8, inappropriate, intense anger or difficulty controlling their anger. You'll see the person get into recurrent physical fights or frequent displays of anger. And lastly, transient, stress-related paranoid ideations or severe dissociative symptoms. Okay, so again, to meet criteria, not just 1 or 2 of these, but 5 of these 9 symptoms, a combination of 5 out of the 9, in order to meet criteria. People with a borderline personality disorder can often have a very difficult time being alone and dealing with rejection. So they can be clingy, but also demanding and manipulative, when you're in a relationship with them. Their emotions tend to run high. And in an argument with you, they are going to be so much better at finding ways to hurt you than you are going to find ways to hurt them. In arguments, they can be absolutely brutal. Now, keep in mind, for all of us, we can show some of these traits, especially when our emotions are running high. But remember, these are traits that are very pervasive and cause problems in multiple areas of the person's life all the time. Antisocial personality disorder. These are folks who show a pattern of disregard and violation of the rights of others. To meet criteria for an antisocial personality disorder, it has 3 of the following 7 characteristics. 1. A failure to conform to social norms with respect to lawful behavior. In other words, they break the laws a lot because laws don't matter to them. 2. Deceitful. There's repeated lying. They use aliases, and they're conning others for profit or just because they enjoy it. Number 3, impulsive, or they tend to not plan ahead. So impulsivity or failure to plan ahead, that's 3. Number 4, irritability and aggressiveness, repeated fights or physical assaults. 5, a reckless disregard for the safety of others. Other people just aren't important enough to even care whether they get hurt or not. 6, consistent irresponsibility, repeated failures to be able to sustain work or honor their financial obligations. Okay? And 7, there's a lack of remorse, indifference, or rationalizations for the people they've hurt, mistreated, or stolen from. You would not make a diagnosis of antisocial personality disorder for somebody under the age of 18, but there has to be evidence of some pretty shady behavior before the age of 15. Now, in the movies, the best representation that I've seen for someone who would probably be diagnosed with antisocial personality disorder is Jake Gyllenhaal in the movie Nightcrawler. If you haven't seen it, it's really, really good and frightening because I think it captures the essence of an antisocial personality disorder really well. Okay, so here are the takeaways for this chapter. Number 1, remember that one symptom alone does not a diagnosis make. There is a constellation of symptoms with significant impairment in multiple areas of a person's life. Okay? Number 2, some of those symptoms can overlap. They are shared by multiple psychological disorders. So, for example, delusions can be present for at least 3 of the disorders that we've discussed already over the past 2 weeks. Number 3, do not try this at home. Accurate diagnosis is difficult for even trained professionals, and we disagree often over the diagnosis for people we see. So do not lose any sleep worrying about if you're a budding bipolar disorder. Sleep will do you more good than worrying about that, okay? Don't start psychoanalyzing yourself, your mother, your dog, your best friend. All right, so in these last 2 weeks, we're going to focus on therapies, which I'm quite excited about. I think this is going to be a really good way to finish out the semester. So work hard, finish strong. You are almost there, okay? If you have any questions or problems, reach out to me by email. My office hours are still on Tuesday night, so if you have any questions, don't hesitate to reach out to me. You guys take care, and I look forward to reading your papers. Bye-bye.